Well, welcome everyone. I think we're going to get started. So thank you so much for joining us today. For those who don't know me or recognize my voice, my name is Jillian McConnell, and I'm a knowledge broker with BrainXChange. The webinar we are proud to be hosting today is part of a knowledge dissemination series offered in partnership by the BrainXChange and the Alzheimer's Society of Canada and the Canadian Consortium on Neurodegeneration and Aging, also known as the CCNA. So I say this every time, but hang in there if you've heard this before. But in case we do have any new participants on the line, I want to provide a quick review just to ensure everyone is comfortable with the technology. So hopefully you've seen my messaging. The audio is provided over the phone, which means that if you're hearing my voice, you're all set. The visuals or the slides are provided by the online link that you should have received in your connection details, and that way you can watch the slides as our presenters speak. On the bottom left of your screen, you'll see a little blue bubble. If you move your cursor or your mouse over it, you will see a chat with the presenter. By clicking on that, the chat pod should appear, and that's how you can communicate with me during the event as well as with the presenters. I do want to note that only the presenters and I can see the notes that you place in the chat pod, not your fellow participants. And that's also where you can send your questions during the Q&A portion. So as per usual, all of your lines have been muted for the time being, and that just helps us minimize background noise, fire sirens, dogs barking, etc. If you do need to ask a question or if you have a concern during the actual presentation or webinar, then please use the chat pod, as of course we won't be able to hear you. The presentation itself is being recorded, so within a week or so it will be up on the BrainXChange website under our archived events section. And we also encourage you to pass that link on to any colleagues who weren't able to join us today. So for the purpose of this afternoon, those are the only features you need to be familiar with. The webinar is scheduled to be 60 minutes or 1 hour in length, and our presenters will speak for about 40 minutes or so, and then we'll have about 15-20 minutes at the end for some Q&A and some discussion. I do ask that people refrain from asking questions in the chat pod until the end of the presentation portion, unless of course it's technology related, and I'll do my best to help you out as quickly as I can. Okay, so now that the technical aspects have been taken care of, it's my pleasure to introduce our topic and our presenters. So the overall title of today's session is Rehabilitation as the Future of Dementia Care, and that's going to include two concurrent sessions. The first, or session one, is Dementia as a Cognitive Disability, and features our presenter, Kate Swaffer, who is Chair, CEO, and co-founder of Dementia Alliance International. Session two is called A Health Professional's Perspective on the Delivery of Multidisciplinary Rehabilitation to People with Dementia, and features Dr. Monica Cations, Research Fellow from the Department of Rehabilitation at the College of Medicine and Public Health in Adelaide, South Australia. So Kate is a PhD candidate at the University of South Australia, completed her Master's of Science in Dementia Care in 2014, has a Bachelor of Psychology, a BA, and is a retired nurse. She is also an Honorary Associate Fellow in the Faculty of Science, Medicine, and Health at the University of Wollongong, where she is involved in a number of research projects on improving care pathways for people with dementia. Kate has been advocating actively for rehabilitation for people with dementia for almost 10 years, and she recently won the Global Leader category of the AFR 100 Women of Influence for 2018. Kate is also the Chair, CEO, and one of the 8 co-founders of the Dementia Alliance International, a global advocacy and support group for people living with dementia. She is a full member of the World Dementia Council and a board member of the Alzheimer's Disease International. As a part nurse and family care partner for 3 people who have died from dementia and diagnosed herself with dementia at the age of 49, she understands well the impact of dementia. She is actively involved globally in human rights, activism, and empowering others to live positively with dementia and have a voice. Monica Cations is a research fellow in the Department of Rehabilitation, Age and Extended Care at Flinders University in Australia, where she coordinates an NHMRC-funded translational study aiming to improve dementia care. She completed her PhD in public health in 2016 with research interests including dementia epidemiology, young onset dementia, and the impact of psychological trauma in old age. Monica is also a registered provisional psychologist and holds a clinical role at the Royal Adelaide Hospital. Monica has worked with people with dementia and their carers for many years across clinical, community, and research settings. So we are very pleased and honored to have both Kate Swaffer and Monica Cations with us today, all the way live from Australia. They've woken up very, very early to join us this afternoon here in Canada. And I say on behalf of all the participants on the line, a very warm welcome to you both. Kate, I believe you're going to start us off, correct? Kate, are you there? It's *7 to unmute your line.
I just joined Kelsey Stewart.
Oh, hello.
Hi.
Hi. We're just getting started. Hi. We're just waiting for our speaker just to get unmuted here. Kate, are you there? Kate, are you there?
No, I'm not Kate. I'm Carla.
Okay. So I'm just going to put everyone on mute again for some reason. It's just hang on a second here.
The conference has been muted.
Okay, so the conference is muted. So Monica and Kate only are two presenters. I'm going to ask just for only you two to press *7.
I'm here.
Okay, is that Kate or Monica?
This is Monica.
Oh, hi, Monica.
Can you hear me now?
Oh, there we go. Is that you, Kate?
Yep, that's me.
Perfect.
Okay, I'm going to mute again.
Okay, thanks, Monica. Apologies for that, but hopefully everyone's understanding considering we're literally talking from each other or to each other from halfway around the world, if not all the way around the world. So, Kate, are you there?
Yeah, sorry about I was using *7 on my computer rather than my phone because I thought I could just use the unmute button on my phone.
Gotcha. Okay. No,
anyway, we're here. That's good.
That's right. So I will leave you to it from here on.
Well, thank you very much for the invitation to speak today. And Monica, thanks for getting up early. I'm used to it, but she's not. And her partner's not either, whereas my husband's already used to getting up very early. It's a great pleasure to be here and to talk about dementia as a cognitive disability. I am really pleased to be here. I'm not sure that works. Brilliant. So just, I guess, a short global overview of dementia. The World Health Organization says that there is an estimated 50 million people living with dementia worldwide and a new diagnosis every 3 seconds. As you can see by the slide, the cost of dementia care, which is provided mostly by family carers, is $818 billion globally, and it's the 7th leading cause of death globally. In Australia, it's now the 2nd leading cause of death for men and women, and for women, it's the leading cause of death. So it's definitely a significant global health issue that we all need to think more deeply about. As was mentioned in my introduction, I was diagnosed with dementia now 10 years ago at the age of 49. I've been advocating very actively for rehabilitation probably since 2009. I attended the World Health Organization Mental Health Gap Forum in 2016, and that was the first time anybody had physically represented dementia at this forum, even though dementia at the World Health Organization comes under mental health. So that year I advocated really strongly to have a 4th category for people with dementia, because under the mental health umbrella they had tucked us into the psychosocial disabilities subcategory, and it's not an intellectual disability, it's not really a psychosocial disability, and dementia is not a mental illness. So I started advocating for them to add a 4th category for dementia to be listed as a cognitive disability. Minority Autism International joined me because they fit kind of in the same category as us. So autism and dementia are now listed at the WHO as a condition that causes cognitive disabilities. And that was important as an advocate or activist for me, because to really claim our rights, we really need the rest of the world to understand that the symptoms of dementia, whilst dementia itself is not the disability, the symptoms of any type of dementia are disabilities. and as such we have the same right as anybody else who has an acquired disability. And I think the background to that for me was that when I was diagnosed, I was an undergraduate university student at the University of South Australia, and unlike the healthcare system who told me to go home and prepare to die, the university simply said to me, we've got a disability department and team that can support you to keep studying at university. So that was a big change for me, to see dementia as a disability, and actually took some getting used to, because the label of dementia in itself is quite negative and disempowering, and then to take on what at the time seemed another really negative label of being a person with disabilities took a little bit of adjusting emotionally and mentally, and the global community of people with dementia have had that same experience. But now generally most people with dementia are claiming their rights as people with acquired cognitive disabilities. We set up Dementia Alliance International in 2014 really to have a stronger collective global voice to not only demand rights but also to provide services and support for us, because generally people find there's very little support in terms of support to live well with dementia. I then attended the World Health Organisation's Rehabilitation 2030 Forum in 2017, February 2017. And again, dementia hadn't been represented. That was the first WHO forum that they held in rehabilitation, a bit similar to the first ministerial conference on dementia that was held in 2015. So that was where I started advocating for rehabilitation and dementia at the kind of more strongly at the global level. So the current post-diagnostic pathway, in my experience, is that it's inappropriate for people who are diagnosed with dementia in the 21st century. It's still based on an old-fashioned view of late-stage diagnosis and late stage of the disease. The diagnosis is difficult to make. It's difficult for people to receive. We are given what I've trademarked and called prescribed disengagement. We are told to give up work if we're younger, or pretty much give up our pre-diagnosis life. I was told to give up work, give up study, get my end-of-life affairs in order, and to start going to aged daycare one day a month to get used to it. And that kind of sent me into a spiral of hopelessness and thinking there was no future for me or for my family, in fact. So dementia seems to have lacked what I would just call plain common sense in care. We've ignored the evidence for rehabilitation and dementia, and I know Monica's that's become one of her focuses, and there's been plenty of evidence around for rehab and dementia since as far back as when I was diagnosed in 2008 and perhaps before that. The post-diagnostic pathway is still based on the medical model of care. It's still based on deficits instead of supporting us with our remaining abilities. And I do think it's stuck in the 70s based on late-stage dementia, when really we knew very little about dementia in the 70s. When I started nursing, I was taught there was senile dementia, pre-senile dementia. We only saw older patients who were late-stage, and absolutely in the late stage it's very wise to prepare for the end. But people are being diagnosed much earlier in the disease process, particularly younger people. There's been a global push for that, and so we need to change the way we're supporting people with dementia to live with it, not just die from it. So most of the current clinical guidelines that I've looked at around the world, they still don't include rehabilitation. They still really prescribe disengagement. They're mostly a pathway of support to the end, not to live with dementia. Even those that prescribe non-pharmacological interventions, they're still very much based on things like just our ADLs, activities of daily living. It's not really based on proactive disability support to continue to live well. Most of the clinical guidelines talk about referrals to community services and day programs and respite centres, and are still too focused on the deficit-based medical model of care. So in Australia, people under 65 with dementia are having to transition to the National Disability Scheme, and I've just recently had an assessment with the National Disability Scheme, and it was very much like my assessment at the university. It was all about focusing on, well, these are the disabilities you've got. Let's see how we can support you to keep functioning as well as you can. So it was a very different approach from the NDIS to what I experienced in the healthcare system. Lucky you can't see the screen. My cat just jumped up on the desk. At the World Health Organization, it states very clearly on their dementia facts page that dementia is one of the major causes of disability and dependency among older persons worldwide. And yet, almost nowhere in the world are we yet supported as people with disabilities. The UN Convention, which was developed in 1948 and adopted back then, is meant to protect every member of civil society in the world, including people with any type of dementia and who have disabilities caused by the symptoms of their dementia. And yet, in 67 years later, the OECD report titled Addressing Dementia, the OECD response, concluded that dementia receives the worst care in the developed world. And when I read that report, it was really sobering for me because I live in a rich Western country, and find out that a major report like that, I expected perhaps that it would be the undeveloped or the developing world where they would find that outcome. However, it's our rich countries where that's been the case. So it's really important from a human rights perspective that we change what we're doing now for people with dementia. In that same report, they talk about rehabilitation. They confirm why it's necessary to demand a human rights-based approach to dementia, which includes equal access to the CRPD in the same way a person with an acquired brain injury would receive if they'd had a stroke, for example, or a car accident with head injuries. I attended the first ministerial conference on dementia. DAI had always advocated for human rights. Other organisations had written reports and always agreed in principle, but no action had actually followed. I was a keynote speaker at that first ministerial conference on dementia. I made 3 demands in my 8-minute speech: that we have a human rights or more ethical pathway of care, and that we're treated with the same rights as all others under the Disability Discrimination Acts and the UN Convention on the Rights of Persons with Disabilities. And for example, when I told my employer that I had dementia, I lost my job. Nobody told me that I had a right back then. This was 10 years ago. Nobody told me that I had a legal right to be supported to stay at work for as long as possible with reasonable accommodations. So for younger people with dementia, we really need to change that. And I asked at this World Health event that research doesn't only focus on a cure, but on pre- and post-diagnostic care and on pre- and post-vention, including rehabilitation. On day 1 of this conference, the then Prime Minister of the UK announced $100 million of new funding into research for a cure. They spent the whole day 1 of that conference, talking about research for a cure. I, as one of the people at the time, there were 47.5 million people estimated to have dementia, kind of became more and more annoyed and wondered why they weren't talking about supporting the people living with dementia and their families who spend a lot of money and time supporting us. So that was why I changed my speech notes and made those 3 demands, and I'm pleased to say that they made it into their final call to action, and in the Global Dementia Action Plan that was launched in May 27 last year, there are some cross-cutting human rights principles that are probably the only part of the action plan that make countries accountable. So the WHO, I won't read that out, but they've recognised that we need human rights for people with dementia and that we've been denied rights for a long time. We've been institutionalised, we've been segregated, chemically and physically restrained. Still, that's happening all around the world. But it really reflects the changes and challenges that we need to make change for people with dementia. In 2016, I think, Dementia Alliance International published a small report called The Human Rights of People Living with Dementia, From Rhetoric to Reality. We've been listening to a lot of people talking about our human rights, but not actually doing anything about it. It's next year we plan to do a much deeper and bigger publication on human rights of people with dementia. But it matters. What matters to us now is that we are empowered to use our rights to access to the CRPD and all conventions. So at the Rehabilitation 2030 Forum, we look at Article 26 of the CRPD, which is about habilitation and rehabilitation. And I think that as a nurse, a past nurse, I always kind of thought that rehabilitation was more about getting someone back to their pre-injury or pre-health condition state. And the goal of rehabilitation is not to cure a person, nor necessarily to return us to our pre-injury or medical condition, but it's to allow us to live well with a good quality of life, to support independence and to promote well-being. So for that, and I think that Monica's going to be talking about healthcare provider attitudes to dementia and providing rehabilitation for people with dementia. And you know, as I said to my own doctor, even if rehabilitation doesn't provide me with a cure, it at least provides me with a much higher quality of life, and that's definitely been my personal experience. So I don't know if anyone has looked at the World Health Organization Global Disability Action Plan developed for the 2014-2021 period. That plan is based on CRPD principles and articles. It's got very good indicators for assessing progress, and that's, to me, after reading that report, that is why CRPD and community-based rehabilitation must be reflected in regional and national dementia strategies and plans, and needs to be included in post-diagnostic pathways for people with dementia. So community-based rehabilitation, a lot of people, when I talk about that, have never heard of it. The aim of community-based rehab is to help people with disabilities by establishing community-based programs for social integration, equalisation of opportunities, and physical therapy rehabilitation programs for people with any type of disability. For people with dementia, that probably needs to include cognitive rehabilitation. But in terms of, if I contrast what I know about CBR now versus dementia-friendly communities, I would much prefer my communities to be basing the programs that they're developing based around CBR and other human rights and some of the articles of the CRPD, rather than on just Dementia Friends awareness programs, because it doesn't really do very much for the people living with dementia and their families. So Dementia Alliance International started with 8 people from 3 countries, one of them being in Canada, in fact, one from Australia and the other founding members from America. We're a registered charity. We are now the global voice of dementia with members this week. We have now a member in our 48th country. Our main goal originally was to provide and empower people to live more positively with dementia and provide online peer-to-peer support. We now very much have become global activists for rehabilitation and disability support. And we kind of work at the grassroots level, but we have started with relationships with the UN and the WHO and a lot of the other international organisations now as well. So what people with dementia want, we want timely diagnosis. And for many younger people, I've heard stories of it taking up to 7 years to get a referral from their GP just to see a neurologist about their cognitive changes. So we need that to change. The clinical and academic community is wanting that to change. In fact, the UK had a subsidy payment, additional payment for GPs who would diagnose people with dementia in the 2014-2015 period. And of course, that then resulted in quite a lot of false positives, but we need a timely diagnosis. We want disability assessment and support at the time of diagnosis, which includes rehabilitation, speech pathology, neuroplasticity approaches, occupational therapy. And when I saw an occupational therapist 10 years ago, the most I was offered was a shower rail and a ramp at the front door, neither of which I still don't need either of them yet. And the only funding in Australia for speech pathology currently for people with dementia is near the end of life when we can't swallow. And for a person like myself diagnosed with primary progressive aphasia, that is far too late for speech pathology. So one of the reasons I'm still functioning as well as I am is I've been having speech pathology for 9 years. So it started early enough in the disease process to make a significant difference to me being able to continue to communicate. So we need our clinical guidelines and services that support living with, not only dying from dementia, and we need them to include rehabilitation. Also in line with all the risk reduction evidence that organisations like the World Dementia Council now are focused on, we need healthcare providers to recommend lifestyle changes as they would if we were diagnosed with high blood pressure or cholesterol or diabetes. We need loss and grief counselling and peer-to-peer support, and we want palliative care plans at the time of diagnosis, not just at the end of life, so that we can think more deeply about our end-of-life issues. And, you know, I think it's still really important that everybody gets their end-of-life affairs in order as soon as they're become an adult, because we never know what's going to happen tomorrow or tonight. So finally, for the last 20 plus years, we've had advocates who, although they weren't using the language of the CRPD, they were demanding inclusion to be included at conferences and other events, and that's Article 19 of the CRPD. They weren't using the language of human rights back then, but they're certainly using it now. We want proactive. They've been advocating for proactive disability support to maintain independence. We've been asking for respectful language and dignified person-centred care. We've been wanting to see no discrimination or stigma, and yet the research still tells us that the lived experience of dementia, people are still experiencing significant levels of stigma. And for the last 10 years, we've been asking for rehabilitation for cognitive and physical rehabilitation and access to the CRPD. So thank you for your time. I'm sorry if I've gone a little bit over time, and I'm happy to take questions, I think, at the end.
Thank you, Kate. Yes, we'll reserve questions until the very end, just so that we make sure that we have enough time for Monica as well, and then we'll sort of open the floor. But thank you so much for your insight and perspective, Kate. We're just so fortunate to have you with us today, so thank you so much. So without further ado, I'm going to pass on the torch to Monica here, and Monica, take it away.
Thank you. Thank you so much. Hi, everybody. And I mean, that's a tough act to follow in any situation, but it is a real pleasure to be joining you here from sunny Australia, although it's not actually that sunny here today, so we're not living up to our stereotypes. No. Thanks so much for the invitation to speak, and to Kate, again, for starting us off. I've known Kate for a really long time, and I still learn something new from her every single time I hear her speak, so that's a real pleasure for me. So I'm going to be spending my time expanding on what Kate has said, because here in our research department, we've been really interested and inspired by these ideas about the potential for rehabilitation to be effectively used in the dementia care pathway. But also as clinicians, we know that there are barriers that exist to widespread implementation of these models. And so we've been really keen to explore that and to try to understand what would need to change to get people with dementia out of the too hard basket as far as rehab is concerned. So I wanted to start with just a note about evidence-based care, and I think it's something that we all need to keep in mind when we're going about our practice, that evidence-based care is not just about doing what the research tells us to do. It's actually this sweet spot that takes into account our clinical expertise and our know-how, but also what the client or the patient wants. So I make this point because in this emerging field, it's really the voices of the clients, of people with dementia, that are are driving this and are starting to be heard. People with dementia have been telling us that this is what they want for a long time now, and it's our responsibility as clinicians delivering evidence-based care to listen to that. So, of course, we all know that dementia is a very complex condition, that experiences vary, and that needs change over time and can very often exceed the support that's actually available. But the landscape's changing, certainly not as fast as myself or Kate might want, but I certainly see that there is change happening. Of course, traditional models of care Kate talked about have been very deficit-focused and task-oriented, but I am seeing quite a rapid shift towards this idea of reablement, promoting independence, meaningful engagement, and person-centered care. And I think a large part of that is because of the advocacy of people with dementia. And so I quite like this graphic. I think it sums up quite well. We're moving away, or we're trying to move away from a disease-centered model towards this kind of asset-based approach. What can this person do and how can we promote that? We're recognising personhood and the wider effects of illness on the family and community, and we're promoting positive outcomes with multidisciplinary non-drug approaches. But even though our thinking is changing, certainly in clinical and academic communities, I think our thinking is changing quite rapidly. The service structures, at least here in Australia, have been slow to catch up. So Kate already alluded to this, but certainly right now here in Australia and in many places all around the world, the care and services that you'll receive after a diagnosis really vary depending on the health professional that you're seeing, as well as some demographic or a lot of demographic factors, particularly here, whether you speak English and how far away from the major city you live. And so you might get referred on to psychoeducation or support groups. Your doctor will probably manage your comorbidities. There might be a discussion about future planning. They may refer for a driving assessment or prescribe Aricept or another drug. And they may refer you on to an ACAT, which is our Australian system for assessing for aged care funding. And as Kate mentioned, this does not support or empower people to stay actively engaged in their communities, this kind of model. And Kate's already covered this, so I won't go over it again, but if we actually ask people with dementia what they want, the support that they're looking for is individualised, tailored and timely. It's maximising their abilities, capitalising on what works really well, and compensating for what's not working so well anymore. So the evidence certainly supports this kind of model. We know that non-drug interventions are effective at slowing functional decline, so that is how well you can do day-to-day things independently. This meta-analysis showed us that interventions like structured exercise programs and dyadic interventions, which are usually occupational therapy interventions that are focused on problem solving with the person with dementia and their support person together, these are more effective than drugs at slowing functional decline in people with dementia. And of course, we have to mention cognitive-oriented therapies as well, cognitive training, cognitive rehabilitation, and cognitive stimulation. I always get these three confused, so this is why I have this handy table. But all of these have good or emerging evidence for their impact on functional decline, sometimes cognitive decline, and also things like quality of life and independence and self-reported goal attainment as well. So these are things we can't be ignoring. And Kate mentioned clinical practice guidelines, and she's absolutely right that I've never seen a clinical practice guideline that explicitly mentions rehabilitation, but what I am noticing is that they are increasingly adopting language that is very rehab-based. It's got really rehab principles built into them, which is really interesting. So these are the clinical practice guidelines for Australia for dementia care, and they say that health and aged care staff should aim to promote and maintain functional and social independence of people with dementia in both community and residential care, and that interventions should maximise independence, function and engagement. So if you ask me, that sounds like community-based rehab. And I did some digging around and I saw that really similar language is used in your clinical practice guidelines over there in Canada. So we should be referring to specialty services to address specific concerns. We should be striving to maintain an optimal level of functioning with non-drug interventions as well as drug interventions. And we should be enlisting support from family, friends and community to maximise functioning and ease caregiver burden. My slide's gone a bit funny there, you can't see the end of that. But the idea is that clinical practice guidelines, which, theoretically should be having a direct impact on clinical practice, are moving towards this holistic kind of goal-based continuous care model. And I think, there's some really positive signs that this is spreading. Everyone's catching on. So Henry Brodati said this at a conference earlier this year: the future of psychosocial treatment for dementia will be combinations, so that is physical and cognitive, goal-directed and continuous. And Henry, as I'm sure you would all know, is one of the world's leaders in psychosocial care for people with dementia, and he's been in this space for a very long time and is very influential. So I think the fact that he is on board and is starting to adopt these ideas is a really good sign that the rest of the field will be following very soon. So what's been really interesting to watch globally happening, and again, mostly because of the advocacy of people with dementia, is that our eyes have been turning to rehabilitation as a potentially effective means by which to deliver this continuous goal-based care that people with dementia want. Kate's already talked about the World Health Organization Rehabilitation 2030 Summit. And so they urge the field to move away from these traditional models of rehab that focus on recovery from physical injury. So instead they said that rehab is a set of measures that assist individuals who experience or are likely to experience disability to achieve and maintain optimum functioning in interaction with their environment. And so they said it should be a holistic approach to management for all chronic diseases. So, it's hard to argue that dementia should not be included in that. And more, the research community is coming on board with this as well. Mary Marshall wrote this book back in 2004, but academics, I think, really slept on this for a long time. But in the meantime, people with dementia were writing more and more about it, and then more about the damage done by the deficit model that we were working under. Last year, Linda Clare, who is an absolute superstar in the rehabilitation space, expanded, or I guess elaborated on some things that people with dementia have been talking about for a while, about how dementia could be framed as a social disability. And from that perspective, ethically we could not deny them rehabilitation. This is another great article that Kate contributed to about, using an assets-based approach and the impact that might have, and I really recommend that one. And then we wrote this article last year, this commentary article, and this is what spurred our invitation to come and speak here today. And in this article, we really asked the question, okay, well, why are health professionals reluctant to do this? What's the barrier? And we proposed a number of hypotheticals that we were able to actually explore in the research I'm going to tell you about in a few minutes. And the research, continues to come out, particularly more and more evidence that people with a comorbid cognitive impairment benefit from rehabilitation for acute illnesses and injuries to the same extent that people without cognitive impairment. So, historically, excluding people from rehab services just because they have cognitive impairment, there's no evidence basis for that practice. But of course, at least here in Australia, there are no structured rehabilitation programs available for people with dementia, not widely, and certainly not outside of research trials. And as I said, people with dementia are sometimes, and in some places often, excluded from rehab for acute conditions. So we decided to conduct some research to better understand this. We're translational researchers here in my department, so we're always striving to understand why particular models of care are or are not being implemented widely. We really wanted to know, what did people with dementia and their supporters want from a rehab program? When they said rehab, what did they mean? What might that program look like? We were also interested in the broader population of people with dementia, and also about how health professionals viewed the value and feasibility of rehab for this population. As clinicians ourselves, we could hypothesize, but we had never seen any research studies actually make a systematic effort to explore these. So that's the answer to that last question of what I'm going to be talking about today. So we conducted qualitative interviews with 16 health professionals, and we used maximum variation sampling to recruit, which means that we purposely looked for a diverse group of professionals so we could get a diversity of opinion. Most of the people we interviewed worked in the public health system, and that's funded by our national Medicare system here in Australia. And most were working in either inpatient or outpatient hospital settings. And most had a mixed client base, so they had people with varying levels of disability, and that's really important. I'm going to come back to that in a few minutes. The questions that we asked were purposely effusive, so we didn't provide any definition of rehabilitation because we really wanted to see what the health professionals would come up with. Were they kind of stuck or was their theoretical standpoint really coming from that intensive inpatient kind of model, or were they able to think more broadly about what rehab could look like? And there were two main themes that emerged from the data, and these were overlapping in some ways, but I'll talk about each of them separately. The first one was about outcomes and the difficulty that clinicians had with identifying suitable rehab outcomes for this population. So a strong theme was that health professionals are very results-driven people, and we derive a lot of professional fulfillment from seeing our patients achieve things. And for rehab professionals, often that can mean seeing people walk again or seeing people go back to work. You know, these really empowering and fulfilling outcomes that can happen. And so in the case of dementia, I thought this quote was very illustrative. If we make goals that people with dementia can't reach, then it's not possible to demonstrate the worth of the program. It's not like when someone has a stroke and you get them from being bedbound to walking again. So the health professionals were conflicted. If the goals are not achieved or they're not meaningful to me, the clinician, then what does that say about me and my worth as a health professional, my identity as a person who helps other people? And then also, how do I demonstrate the value of the program to my boss or to my funders? So in some ways, it's really not about the person with dementia at all, but more about me, the health professional, my identity and the demonstrable worth of the program that I'm delivering. There were also a lot of definitional issues. So people were caught in a lot of cases in that intensive and inpatient physical rehab model they probably learned in their studies. And they struggled to see how rehab could be applied beyond that. But then on the other hand, some clinicians talked about activities that we might not generally consider rehab activities as perhaps being part of a rehab program, things like pain management or advanced care planning. So people really lacked a frame of reference to understand what rehab would involve and what it would really look like in this context, which, you know, is not surprising. This is a really emerging field, and, you know, I think us as a research and clinical community, we really need to do the work of developing the evidence base and determining, you know, the structure of what this might look like. The second theme was participation. So I wanted to keep going. I'll go back. So there was also a general argument about whether palliative approaches and rehabilitative approaches could overlap. So most dementia care takes this kind of palliative approach. So it focuses on psychosocial issues, has this kind of compensatory approach, and a lot of focus on placement issues. And so some clinicians question whether rehab therapies that are about, you know, in some cases recovery or supported participation, these kinds of ideas could theoretically overlap. Certainly I think they can, and I'm sure Kate would agree, but this is a theoretical challenge for our clinicians. We noticed that there was a general tendency to speak about dementia in its most severe form, so people with severe disabilities living in residential care. And this is really interesting, especially given that a lot of the clinicians worked with people who were in the early stages of dementia, but they weren't acknowledging the often very long period that precedes those severe disabilities, which offers a lot of opportunity to optimise function. So that was disheartening for us, and I think it's something that has been documented in the literature for a really long time. Some clinicians were worried about offering false hope, but most could agree that addressing that issue would just be about messaging more than anything else. And so false hope was a much less important issue than we expected it to be. A lot of clinicians mentioned that in their other populations, false hope is a challenge, but that they were quite skilled at addressing that. So they didn't see that that would be a huge difficulty in this population either. But some could acknowledge the benefits regardless of whether anything was actually achieved. So the person being active, their family feels that something's being done, and so on. So, you know, perhaps it's worthwhile even if nothing is actually achieved. Okay, so as I was saying before, the second theme was participation. So clinicians identified a range of different things that they perceived were barriers to participation in a rehab program. So this insight was understandably a big one. So this person said that seeing the benefits for themselves is a problem, because if they're going to go, there's nothing wrong with me, then they're not going to want to participate. From a service provider point of view, I'm not entirely sure how we move ahead with that. And so, you know, how do we support people who don't have insight into their condition or don't see the need for rehab to be involved? But some clinicians could see a benefit even if the person with dementia did nothing in between the sessions. You know, at least they're engaged and active for at least that hour or for however long the program would go for. The memory loss and other cognitive changes were perceived as a huge barrier for many clinicians. So this quote sums that up quite well. A lot of professionals that I've come across have said the patient is not going to remember this, how to do any of this, so why are we doing it? And, you know, this is a phenomenon, sorry, I'm losing my words, that we've known about for a really long time in dementia care, you know, that people with dementia can't do it, and so let's just not even try. And that really breeds this sense of therapeutic nihilism, which is, you know, this idea that nothing can be done, so let's not do anything. And, you know, that is really damaging and has been damaging to people with dementia in their care for a very long time, and, you know, is a big issue that we're going to need to address. And, of course, behaviour change is another one as well, responsive behaviours, whatever we'll call them. This area is something that almost every clinician worldwide would probably report that they need support to address and manage better. And so in all contexts, this was mentioned by almost everybody. And so in terms of making sense of this, I'm a clinician and as well as a researcher, so I really wanted to leave you with some clinical messages that you could take away. And the first thing I think is that many of the clinicians we spoke to didn't feel that dementia was their business, but it is. Dementia is everyone's business. We will be seeing people with dementia pop up in almost every care setting, and so we all have a responsibility to be providing best practice care, even if we are a rehab specialist who usually refers people with dementia off to the geriatrician or whatever it is. It's still our responsibility to, you know, understand these people's rights, their care needs, and support them to live well. The reluctance or barriers to accepting rehab as relevant to dementia care seem to be related to this broader undervaluing of people with dementia and their right to a good life. And so I think we really need to start there. And we need to be reframing our understanding of rehabilitation and what it could look like. What about a continuous and adaptable set of therapies that address the particular abilities and goals of the person? What about prescribed exercise? And also, what about valuing the more modest goals and outcomes that might be possible as just as valid and rewarding as walking again or going back to work? How can we reframe those kinds of outcomes as, you know, being just as important to our professional identity as seeing a person, you know, gain full recovery? The winds are really changing on this issue, and we have an opportunity to be agents of innovative change here, to be influencers among our colleagues. This is almost certainly where the field of dementia care is headed. You know, whether or not we use the language rehabilitation, I think that, you know, we cannot deny that this continuous goal-based care is where the field is heading. Kate alluded earlier to the division of disability and aged care in Australia, and the disability sector has moved quite firmly in this direction, and I think is providing a good model for where aged care is going to be going. And I think since you're all here, you're all really well placed to be our future leaders and to be the change agents that are out there and talking about this and questioning why we think of rehab the way that we do. So in terms of us and our research, we've just finished talking to people with dementia to understand exactly what they want from a rehab program. So we'll publish the results of those interviews soon. We're doing a survey of the wider population of people with dementia to understand their thoughts. And there's a real push in the field to expand the evidence base, to refine exactly what works and at what dose and so that we can provide the evidence base and also the cost effectiveness for funding bodies as well, which is just as important as demonstrating the effectiveness. And we're working hard to provide a frame of reference so that clinicians and policymakers can understand what a rehab service might look like in practice for this population. So that's everything from me. Thanks so much again for the opportunity to speak with you all today, and for Kate for joining me. And I'll pass back to Gillian.
Thank you, Monica, and once again, thank you to you as well for this interesting presentation, and I think you've made some excellent points, so thank you for that. We have 10 minutes remaining with Kate and Monica this afternoon, so I do want to open up the forum for some questions. Before we do that, just to remind you, there's a couple of ways in which you can ask your question. One, you can ask over the phone by pressing *7 on your individual line so that you're no longer on mute. But only those who intend on asking a question, please hit *7. Or you can type your question into the chat pod, which some of you have done already. And I do want to remind you that only the presenters and I can see the question that you've posted. I'll do my best to sort of allocate which questions to go to whom, but if you could direct the question to the individual, if you're looking for their response specifically, that would be very helpful. And also, as per usual, we're going to post a few poll questions as we're going through the Q&A. So also as a reminder, your questions, or your answers rather, are anonymous, but they do help us tailor future webinars. So I invite you to take part in all of those as we're going through. So we'll start on actually just, a couple of, I guess rather a comment at first, but I think it's important to note, and that is that this participant highlights the need to see the whole person and not just the label of dementia. She says, "Thank you, Kate, for your extreme advocacy in this area. Everyone needs inclusion and a purpose no matter where they stand to help support a health community for all." And also that it's not just patient values that we have to look at, but patient expertise of lived experience, and that needs to be acknowledged. So thank you for those comments. I'm going to, this is just sort of a little communication that was going on during the chat pod a little bit, but I think I'm bringing it up because I think for people it might be interesting to hear, and that is whether, whether it would be useful to do some sort of research project that compares, I'm going to rephrase that here. To do some kind of financial comparison or projection on how much money could be saved by providing persons living with a dementia with rehabilitation versus doing nothing, and whether that research has been initiated anywhere or if you know of anything. So Kate, I might direct that to you since you were talking a little bit about it earlier, whether there's a study that compares the cost of providing people with a dementia diagnosis with rehabilitation versus doing nothing in terms of overall costs.
Can you hear me now?
Yep.
Mm-hmm. Yep, yeah. I did answer that message in the chat box, but I've tried 3 times now to get a research project up to do an analysis, a cost analysis of providing someone with rehab versus not providing someone with rehab, and haven't been able to get my research project approved. And I think partly it's probably because people who review research applications probably have the same opinion as most of the healthcare professionals currently, in that it's a bit of a waste of time to even provide rehab for people with dementia. There's another project that I'm involved in with Associate Professor Li Fei Lau, and I can't remember, Monica, whether you're part of this one. It's providing a lifestyle program for people who've been diagnosed within the first 6 to 12 months of their diagnosis. So we're providing peer-to-peer support by other people with dementia who are living well. We're providing some rehab, some socialisation programs, some exercise. It took us 3 times just to get that project funded because we didn't want the buddy or lifestyle coach or mentor, whatever, we ended up calling them lifestyle coaches, we didn't want them to be the family member or carer because often they're the people that disable us more. because they, out of love, they kind of take over from us, and actually we need them to stop doing that. And so the ethics people kept saying, oh, but you have to have a carer involved. And, you know, it took us a lot of effort to explain why we didn't want a carer involved as a mentor or the lifestyle coach. So we've now got that project up and running, and we've got some participants in it. So it'll be interesting to see the difference in even just wellbeing scores that we'll look at the end of the project. But, yeah, I haven't been able to get a research project up to do a cost analysis of it.
Thank you for that. So, Kate, this question is to you again, and or Monica, maybe you can chime in as well with your expertise. So this individual was very interested when you mentioned that you yourself, Kate, have been going through or involved with speech therapy for aphasia, and she was asking if that therapist has special training that they need to achieve in order to work with persons diagnosed with the dementia, and how widespread is the use of that type of therapy, do you know?
I think in Australia, I can really only speak to that topic in Australia. There's no funding for speech pathology in the early stages of dementia. So unless you can afford it, you can't get it anyway. I had 3 or 4 lucky breaks, if you want to call them that. My speech was quite a lot more impaired than it is now. When I was first diagnosed, and my neighbour is a past speech pathologist, and she said to me, who's your speech pathologist? And I said, I haven't been offered one. She said, well, clearly you've got speaking difficulties and other communication issues. You need a speech pathologist. So she referred me to a friend of hers who works in one of our public hospitals here. But it probably took me 3 months of teaching the speech pathologist about dementia, and then working together before she really knew what to do with me, so to speak. But I think that speech pathology needs to have some specific training for dementia in it. My disability advisor at UniSA is just finishing her master's in speech pathology, so I'll ask her whether she, how much was in the course about dementia. I'm suspecting not much, because there's not very much about dementia in medical or nursing training either.
Thank you. And Monica, anything to add?
No, not so much. I think, as I mentioned earlier, young people with dementia are eligible for disability support services, and they would be much more likely to have speech therapy included in their package or their funding package. But for older people, I really don't see how you could work that in to an aged care funding package. So I think even the funding structures that exist, certainly here in Australia, are not very supportive of that kind of care, which is a shame.
Okay. Monica, this I'm going to address to you first, but again, of course, Kate, chime in if you would like. This person is saying, have you ever looked into recreation therapy as a means of rehabilitation for persons with dementia? I noticed a lot of the concepts that were brought up are based off the rec therapy model, but it wasn't ever mentioned specifically.
Yeah, absolutely. And I think, you would have noticed I spoke quite generally about what a rehabilitation service might look like, and I think recreation therapy would definitely be a part of that. I've not seen I'm not aware of trials specifically testing this. I'm sure that they exist. But I think that what you'd be looking at for this population would be a multi-component type of therapy, and recreation therapies, I think, would be a part of that. Again, the first step, I think, is to really strengthen the evidence base and, as was mentioned before, demonstrate the cost effectiveness, because that's the key to getting services available on a widespread basis. So I think the more we do that, and the more that we show how effective recreation therapy is, I think the more that we'll see it happening.
And do you have just 1 second. Do you have rec therapist staff working in day programs and long-term care homes in Australia?
I think we do, but they're not called rec therapists. I think they're called lifestyle assistants. Do you know, Kate? Yes,
they're sometimes called lifestyle therapists or diversion
therapists.
But I think from the person with dementia's perspective, we wish that the healthcare community would stop calling everything that's a normal activity therapy. Like before dementia, if I was doing an art class or doing a recreation, like, I don't know, golf or I don't play golf, it's whatever, none of it was called therapy. And one of the things that puts people living with dementia off is when you start calling it therapy, it medicalizes it, and they think they're not going to enjoy it.
It's something to do versus something to enjoy.
With my dog, it's pet therapy.
Why is it before dementia when I went walking 10 Ks a day, it was called walking, and now it's seen as a challenging behaviour and labelled as wandering? I mean, that's just one of my pet hates, but Monica knows that already. But, people still want to walk, whether they've got dementia or not.
Right. I think that's an excellent point, Kate. And did we have someone on the line that wanted to ask a question? Oh, perhaps not. I thought I heard someone. Okay. Just wanted to make sure. But that's an excellent point, Kate, on how we label things and how the impact of that labeling can have just on our overall sort of mental health, right, as we approach something.
Yeah. And I think, I did focus groups for the second book that I wrote with Li Fei Lau, and all of the people with younger onset dementia and even people in their late 60s and early 70s said, look, we're just not going to go to a daycare centre. That's where we took our children.
Right.
So we need to call those places different things.
May I make a comment?
Yes, please do.
Yeah.
Hi there. My name's Merla. I'm listening in from Canada and thrilled to hear the presentation. We have started a service here called UQuest, and our express purpose is to normalize the situation for the people in the community. So we've partnered with our recreation center at the SAIT campus. So it's a post-secondary campus, and they have a wellness center there. And so far, we've managed to attract funding to allow us to go one day a week with our pilot group of participants who are greatly enjoying being given the choice of things to do in the community. So I think the person who spoke up about the recreation therapy approach, this is the model we've chosen because we think it best imitates life. And unfortunately, funders are looking for that clinical perspective. So we've chosen the recreation therapy to represent how we're going to take that rehabilitative choice, but how approach, but how to give the participants a choice within a recreation center how to pursue their own interests and according to their needs with that adaptive support Monica spoke of. And just before I finish, I want to say that I think Monica is my favorite researcher, and Kate the favorite spokesperson about what's happening, particularly for young onset, because that's what our focus is. So our pilot is just a few weeks in, but we're doing well and getting great feedback from families.
That's fab, and I'll give you your money later, for a compliment.
No, your article, Monica, your article on, it needing to be flexible, tailored, meaningful, whatever, that is exactly what the families are asking for. Exactly. These people, their caregivers need to be at work.
Absolutely, yeah. And I think you've touched on such an important point about the challenge that we face as clinicians and as researchers and as policymakers to balance these things. You're right. Funding bodies want to see that clinical element. The general public want to know that their money is going to something that is cost effective and that is actually helpful. But then, of course, there's limited money. There's so many competing demands in how we design health services. And so, this is something we just need to keep in mind,
But I think that goes back to Kate's comment, which was a little bit of common sense would be nice. All of us would like to, no matter what our disability, we would like to be treated like human beings and have some choices. And as you say, have an art class as opposed to having therapy. We use that therapeutic approach term with the clinical people. We never use it with our participants.
Yeah. I mean, the common sense approach in residential care most residents living in assisted living have all got vitamin D deficiencies, and that's probably because they never see the light of day. So if we took them all outside every day and got some sunlight, they'd probably reduce their vitamin D deficiencies, and they'd have a much better experience of living as well.
Mm-hmm. Mm-hmm. And the simplicity of being able to get at some of these collaborative approaches, we've certainly been told by our families their biggest challenge is the diagnostic delay, the perception that it couldn't possibly be, that it's not on the menu. So our co-founder, her husband was diagnosed at 48, and 11 years later, he is one of our key volunteers and, very engaged in life because he's made it a personal mission to stay active and get outside every day. And I'll just put in a little plug. He's on his 575th day in a row of playing disc golf. And he just makes it, he just makes it his mission in life. So we're trying to support those choices, and our recreation therapist makes it a priority to find opportunities for us to blend into the community.
Excellent. That's wonderful. Thanks, Marla, for your plug. I think that's important, and also just to hear what's happening in our own neck of the woods here in Canada. So congratulations to you, and I wish you all the best in your pilot and that and future success. I am aware of the time, and I know despite the early hour in Australia, Kate has to go. So I've
got another meeting.
Yes, another meeting already. So I'm going to close now. I want to say an immense thank you to Kate Swaffer and Monica Cations. We are just so thrilled and honored to have you here with us today. And thank you so much, as I said, for getting up so early and contending with the time difference and the day difference. It's Wednesday morning in Australia right now. So thank you very much for providing your insights, your experience, your lived experience. I really can't thank you enough for spending time with us this afternoon. And again, I say this every time, but thank you to our participants. We wouldn't have a reason to be doing this if you all didn't join us. So thank you to all of you for the great questions and comments. Very much appreciated. I do want to make a plug for our next webinar on Thursday, December 6th, which again is a CCNA BrainXChange ASC webinar, and that is going to be focusing on the changing definitions of Alzheimer's disease and the role of biomarkers. So a bit of a turn from what we're talking about today, but an important topic nonetheless, and that's featuring Dr. Sharon Cohen. So I encourage you to check that out. Registration is open for that event, so you should have received notice in your email inboxes last week. So thank you so much for all of you attending today, and again, a final thank you to our two presenters.
Thank you for the opportunity to have us.
Invitation.
Yeah.
Wonderful.
Bye, everyone.
Bye-bye. Take care.